When someone is struggling with their mental health, the pain is incredibly real, but it's often entirely invisible. It's a chaotic, highly personal internal reality that doesn't usually look like a broken bone or a fever. The American Psychiatric Association defines a psychological disorder as a condition marked by cognitive and emotional disturbances or abnormal behaviors that actually impair how a person functions. But to actually treat these invisible conditions, doctors and therapists can't rely on guesswork. They need an agreed-upon, objective dictionary to translate subjective distress into reliable diagnoses. Having a standardized vocabulary means a clinician can prescribe the correct medication or therapy. It also means health organizations can track illness trends across populations, and patients can get their treatments covered by insurance. If we didn't have a shared diagnostic framework, mental health care would stall out. Every diagnosis would just be one doctor's subjective opinion, making consistent care and medical research virtually impossible. You might expect there to be one universal rulebook for this. There isn't. The global mental health field is governed by two competing standards. First, there's the International Classification of Diseases, or the ICD-11. It's maintained by the World Health Organization and serves as the global standard for classifying documented health conditions. Then there's the Diagnostic and Statistical Manual of Mental Disorders, specifically the DSM-5 TR. This one is published by the American Psychiatric Association and is heavily rooted in the United States. Both of these foundational texts went through massive updates in 2022, keeping this dual system dynamic highly active. These two texts look at the exact same psychological conditions, but they frequently disagree on how to define them, what causes them, and the specific criteria needed to make a diagnosis. The choice between these two manuals dictates how patient data is collected, how billing is processed, and how the entire framework of clinical psychology is applied in a specific region. Let's look closer at the WHO's manual. The ICD-11 is designed to catalog every single documented health condition on Earth, physical and mental. It covers everything from broken ankles to major depressive disorder. That accessibility makes it a powerful tool for health management and epidemiology. It allows organizations to track morbidity and mortality rates on a massive, global scale. The trade-off is breadth over depth. Because it covers the entire spectrum of human disease, its diagnostic criteria for mental health do not include the complex social consequences or granular psychiatric profiling you find in a dedicated manual. The ICD-11 is optimized to support global public health infrastructure. It prioritizes tracking data across borders over deep diving into individual behavioral nuances. The DSM-5 TR operates with a completely different focus. It ignores general physical health to focus exclusively on categorizing hundreds of psychological disorders. But there is a reason professionals pay that premium. The DSM-5 TR provides an incredibly descriptive, rigorous set of criteria for diagnosis. It requires clinicians to deeply evaluate how a patient's symptoms impair their daily social functioning and everyday life. It trades away global accessibility and affordability to establish the highest possible standard of clinical precision for specialized psychiatric research and localized care. Because these two manuals are governed by entirely different bodies, they routinely clash over how to define the exact same disorder. Take attention deficit hyperactivity disorder, or ADHD, as an example of how this clinical friction plays out in the real world. On the left side, the DSM-5 TR requires exactly 9 specific inattention symptoms for a diagnosis. Contrast that with the ICD-11 on the right, which lists 11 symptoms, including behaviors not found in the DSM at all, such as daydreaming. The immediate result of this mismatch is severe. A patient evaluated under the ICD-11 might receive an official diagnosis and a prescription, while failing to qualify for help under the DSM-5 TR. When you draw subjective borders around psychological conditions, a patient's access to life-altering treatment often depends entirely on which book their local health system purchased. How do healthcare professionals choose their tool? We can map this to daily job functions on this quadrant chart. Look at the public health and global utility quadrant. This is the ICD-11's domain. Its primary users are epidemiologists, health information managers, and public health officials. Their daily reality requires tracking large-scale disease burdens across populations and maintaining standardized billing everywhere. Now look at the clinical focus and localized utility quadrant. This is where the DSM-5 TR sets, utilized by clinical social workers, specialized psychiatrists, and psychology researchers. Their mission relies on extreme precision for one-on-one treatment planning and making sure research methodologies stay perfectly consistent from one domestic study to the next. A professional's diagnostic toolkit isn't chosen based on which manual is objectively better. It is dictated entirely by whether their core mission is to treat the individual sitting in front of them or to track the health of a global population. Despite their differences in scope and price tag, both manuals share a dangerous limitation. By their very nature, they force the oversimplification of human behavior. When you distill a person's complex psychological distress into a rigid set of checkboxes, it is easy to ignore the vital cultural, environmental, and social contexts that influence their mental state. This leads to stigmatization. Applying a formal medical label is often necessary for treatment. Patients often internalize the negative societal judgments tied to their label, lowering their self-esteem and pushing them towards dysfunctional coping strategies. Diagnostic manuals are indispensable, standardized compasses required to navigate modern healthcare, but they are not encyclopedias of absolute truth. They must never replace a clinician's understanding of the holistic human context.